Hello, today we will look at this project called this research project and quantitative study on the predictors of dynamic aging. So we will seek to make a connection between adults' beliefs and perspective and how it reveals their current health status. So, our social problem includes a compromised understanding of in our healthcare and our assessment, and with this compromised understanding of in our healthcare and of people who are getting sick or people who want to live long quality lives, and we're not assessing properly, it leads to inadequate outcomes and inadequate interventions. And another problem is we have rampant mandates because it's a highly regulatory area, taking care of one's health, and the many more high morbidity and mortality rate that is imposed upon our population in the US. And do these regulatory align with what's really going on? We will seek to try to address a social problem, and this can always many problems can be addressed by being data driven and creating data infrastructures to improve some of our major public health issues. And what this research study does is move beyond the descriptive and aggregated data, you know, that is typically used in operations, to moving to what is statistically significant, so that we do assess in a way that's meaningful and we do mandate reporting around elements that and variables that align with what really the problem is and that can make a change. And the research question posed is, to what extent is the perception of one's view on a rich spiritual life and adequate finances in older age reveal about their current health condition, and vice versa? Based on one's current health condition, what do they likely value that will be important? Will they value this rich spiritual life during older age, or having enough finances and not being socioeconomically compromised? So, our null hypothesis states that there will be no connection between one's current state of health and what they want in older age or perceive as a healthy longevity approach to aging. Our data source will come from a secondary data set from the National Council on the Aging and International Longevity Center, which is aimed to identify perception of aging from the adult population in the US, 18 years and older, both males and females across the nation. The statistical test that will be used is a multiple regression, because in the data set it was presented as ordinal variables, but I recoded them to interval ratio given that they were numbered anyways. It was an easy recode to get this interval ratio on the identified variables. And as Walden University states, multiple linear regression is a powerhouse in social science. So, variables identified that link back to our research problem is a rich spiritual life as our independent variable, and socioeconomic economic status and how important um, money is in aging. And that is a key social determinant that is being mandated by our regulatory for assessment and reporting, and the interaction between the two in case there is a significance between one or both. And we will control and make this model re- more robust and to reduce type 1 error, uh, and and bring it closer to causality with poor health. What one views in old in their latter years, in their retirement years, how do they perceive poor health? Is it an important part of what of dynamic aging? And our dependent variable will be their current health status, which is unique to all the other variables in this model. So multiple regression was ran after being recoded, having the control variable and the interaction. And the overall model resulted that there was statistical significance in the overall model. The R squared was at 21%, the model's overall variance, which tells us this is a moderate effect, and that this model is reliable. And so the variable breakdown, there was no significance in the intended variables of study, which is spirituality in older age and the views of spirituality in older age, and lack of money, socioeconomic status in older age. And of course, the interaction between the two is also not significant. What was significant was the control variable, and that one's view of poor health was very important to them in old age as it relates to their current health status, with a negative a slope here at with minus 40.45. So let's discuss more what this means. Overall, the model, there's a partial acceptance of the null hypothesis because the control variable was significant. And so, therefore, we can say that poor health in old age did control well and does play a significant role in one's health status and how it shapes their views. Or, alternatively, the better one's health status, current health status is, the less important it was to address poor health in their older age. So, why is that? Maybe there is this, if I feel well now, I'm not thinking about what it's like when I'm older, and valuing the role that being in poor health plays when I'm retired. And that requires a further investigation of why there's a negative slope there between these two variables. And this can shape effectiveness of these regulatory mandates and how we assess. And why this is important is that there is so much buzz about around social determinants of health, assessing socioeconomic status, assessing access to food, assessing this, but does it really have a statistical significance to the most important outcomes? And in this case, for older people, they perceive that it does not. Do maybe they don't know better, but this adds that that is another area to incorporate in a holistic and valid health assessment, is what the patient feels and believes is important for them. But what is important is their view on poor health. And diverting, what this can do is divert energy to areas that do have value for the intended outcome. Perhaps spirituality. I mean, and I admit biased. I am biased. I would think that money and spirituality would be so important to what people think would make their older life fun and rigorous and dynamic, lead to dynamic aging. But apparently, there is no significance in what adults feel, how that plays a role when they retire. And it may not, and that will take a different type of data set that's not looking at beliefs and perspective, but actuality, which there are, like the BRFSS. So, if for some reason we find that the perceptions of people are accurate and spirituality and money is not important for mortality and aging and retirement, then we cannot waste assessment and mandate time around those two areas. Perhaps other determinants are very important, like education or food access, or maybe it's important in oncology care, and that we should shift our energy per specialty, and that this is how social determinants and holistic care has to be begin to be addressed just as much as a medical specialty, that there is a niche and selected amount of social determinants per illness to have value in social determinants of health. And that's some of the social change in it that can happen in addition to properly derived interventions and programs. Rationale for these uh, abundance of mandate that is consuming in our healthcare administrator so they do meaningful work, and to start to derive a meaningful holistic health assessment that includes the socioeconomics, the social determinants of health that actually matter. And this is to prove that it's not just about what's mandated, and it's not just about what sounds like it should be important, but what does the patient or client feel is important to them? Because they may be right. They may be the ones that could help us shape our data infrastructure. Thank you.